By the people, for the people, the gathering to get healthcare now. Chapter 6. Step-by-step reorganization will lead to open systems. Assume that the existing physician associations that contract with Medicare, Medicaid, HMOs, and commercial plans are open to contracts between providers and their individual patients to carry the nudge physicians have gotten from government into the marketplace. The physician's goals would be to determine the health status and profile of each patient and to personalize care and treatment so that most of it can be managed by the individual patients. The main barrier to that goal is the time spent between the patient and the healthcare provider is compressed so much that the patient cannot learn and the provider cannot teach. The next barrier is that communications within the community are restricted in silos that retard learning and stifle healing. As a comparison, people think that language and math literacy are benefits for the whole population. A few hundred years ago, that was not the case. Medical literacy must catch up with language and math literacy, and just paying for services does not accomplish that goal. So, step one is to let the patient pay directly for their basic care so that the patient and their chosen provider can act freely in the quest to restore health. This idea does not rise to the level of insurance or the pooling of resources because the amount of money needed to have basic care is within the budgets of individual families and their close friends and relatives. Physicians and patients are already enabled by the established practice of concierge medicine and medical savings accounts. We've not addressed the possibility that a patient could fail financially in their agreement with the provider, but a gift circle within the community is an easy remedy for that problem. It's done frequently in catastrophes, and there's no good reason why it cannot be done routinely in self-organized groups. Government assistance in overall healthcare program in which the patient's savings account is driving their access to healthcare and in which there is price control and insurance against large expenses is needed, but it is not the substance of the Accountable Care Act and unlikely to be in any reform of that act. This type of national system, if a top-down approach were used, is like what was done in Singapore at a cost of insurance in the United States with much better outcomes. Perhaps in Singapore, people see community responsibilities as a prior condition for free enterprise. The U.S. is not yet controlled by those types of people. However, we need not await political change to have a high-performing system. We can use the nudges we've gotten to seize the day and make our own patient-centered system. In comparison to the high cost of healthcare in the U.S., the cost of primary care is a small part of it. Consequently, an individual patient can pay a physician for primary care services, laboratory, imaging, health education, and care coordination for about 6% of a minimum wage, or about 2% of an average wage. The Singapore model, which is about 1/3 the cost of healthcare in the United States, has a savings rate of 3% of wages. Perhaps the difference between the 2% we need and the 3% they collect is a surplus to assure that all the people in Singapore have better health care. In the USA, that surplus would be our gift circles within the individual cooperatives. The peculiar thing about our proposal for the primary care physicians is that concierge plan pays the practice more than they usually collect from insurance of all types. This includes patients' co-payments and deductibles, and the practice adds to the money from the insurers. The concierge payment is 30% more than Medicare rates. Yet the access to care issues are eliminated, and so are the frequency of acute care episodes. The utilization of hospitals and emergency facilities drops, and so do the attendant costs. The incentive for maintenance of the patient's health works best when the patients know their bill has been paid in advance and needed providers are ready and available to use. The incentive for providers is the established patient relationship and the knowledge that the patient regards them as his or her medical home. With these conditions in place, any bonuses earned by providers because of good care coordination and reduced spending on other medical and hospital services is the seal for continued participation as a concierge medical home. The organized, patient-centered healthcare system requires an association of patients and physicians that's approved by various state departments of insurance as a purchasing group. In some cases, state laws require a license for these entities that they call discount medical plan organizations. One such group, Senior Patient Association, which does business as patient-physician cooperatives, started in Texas in 2004. The members of PPC made concierge payment agreements between individual patient members and individual group practice providers. Additionally, PPC required a qualified association as a purchasing group for its members that was as limited or comprehensive as they required to comply with the Accountable Care Act. The purpose of the group health policy was to fund specialty and hospital costs that were beyond the funds available in the concierge payment plans with individual providers. The result for patients was to have all the resources needed to get health care without exclusions and for a price that was below the usual market charges. PPC has shown that people in small communities can create cooperatives quickly with few barriers and very little money.